Thank you so much for joining us on It's Time today. We are your hosts. I'm Lindsley Donnelly, your citizen scientist and your longevity expert for midlife women.
And I'm Dr. Jen Wagner, physician and holistic performance expert. Welcome to It's Time, powered by Prosper. Just a quick reminder, the information discussed in this podcast is for informational and educational purposes only. We are not offering medical advice, nor are we entering into any type of physician or clinician relationship with listeners. Always consult your healthcare provider before beginning any new fitness, nutrition, or lifestyle changes to ensure they're right for you. Your health and safety is our priority, and let's keep it that way. Thank you.
All right. Well, welcome everybody to It's Time. As you can see, we're in various locations today. And so excited. I'm sorry I'm squinting as I look into the sun, but we are so excited to have Yumi here with us today. Linz, you want to give a more detailed introduction?
Yes, so we have Dr. Yumi Ando here with us today. And we are so happy to have Yumi with us because she has been kind of leading the charge in thinking about menopause and midlife, overall health and wellness for women based in the Bay Area. I got to meet Dr. Ando about a year ago and have just come across a myriad of her conversations in the context of blood flow restriction, trying to look at effective physical fitness in this phase of life, as well as in the context of menopause hormone therapy, MHT. And so we really wanted to bring Yumi on to talk with us about some of the components in the menopause portfolio, the breadth of things that are impacted that maybe we haven't heard quite as much about, and hear more about the way Yumi and her practice are helping address all of the issues for women today. So Yumi, thank you for being here.
Thank you.
Thank you so much for having me. I'm super excited to talk about this topic. It is really an early passion of mine. I can just give you a quick background on how I got started in this. About 10 years ago, well, I've been doing concierge integrative medicine. I'm double board certified in both internal medicine and integrative medicine. So I've done fellowships in both. And I was thinking about this in preparation for today, thinking, how did I get started? About 10 years ago now, in 2015, I knew nothing about hormones. Safe to say, I had just left a multi-specialty group practice to join an integrative clinic. And one of my motivating reasons was because the co-founder of the clinic was really well-versed in BHRT, which is bioidentical hormone replacement therapy. And at the time I was like, I didn't know anything about it. He was prescribing a combination of a compounded biest. And I'm like, oh my gosh, what is that? I want to learn more about it. How do I learn more? And even as an integrative doctor and trained obviously in conventional medicine, and you guys probably know this, we do not get trained in hormones, right? And you can attest to that.
Not at all.
Very hard to get hormone training. So I was thinking of this sort of I would be an apprentice and really start learning about this. So my journey actually started about a decade ago. And I've been doing this I actually did additional training through the A4M, which is the Medical Society. They had a really good kind of 3-month intensive on hormones. That's sort of what I know and do. And then honestly, a lot of what I've learned is just by doing it, because you have to understand pattern recognition. You have to have treated many women who go through, different changes in hormones, checking levels, understanding the relationship of dosing to serum or saliva testing. And so here I am. I would say, looking back, like the very first woman, I still have her in my practice, the very first woman I put on hormones, I said, I'm going to experiment with you because I don't know what I'm doing. And we went through this whole journey together. And I look back and I'm like, oh my gosh, I would have just put her on this and that and we would have been done. But she was very patient with me as I was learning in this process.
I think that's I just want to highlight that again, as we get a lot of questions about how do we find a practitioner or healthcare provider in this space, that it's really hard. And it is healthcare providers that have sought this training out themselves. And kind of gone through some, what we're going to call non-traditional training platforms to get it. And so I think that I just really want to make that emphasis that you're not alone if you're struggling to find a healthcare provider in this space, because it's really hard as a physician to get the education. And I think this goes back to our expanded definition of what women's health is, that it is so much beyond just what even OBGYNs get trained in their residencies and in their educations. And so I just, want to say thank you for doing that work, because it's hard, it's expensive, it's time consuming when you're a practicing physician, and just reiterate to our audience that, it is hard to find people that have your level of expertise in these areas.
Yeah, and
But
I will
I,
say to echo that, I practice in the Bay Area, right? So we're overshadowed by Stanford. There's so many doctors, Jen, as you know, in this area. Until now, and I will say that now, menopause is sort of the rage, and more doctors are thirsty for knowledge, which is great. We need many, many more. But there are only 3 conventionally trained physicians in the entire Bay Area who are
Hmm.
trained and able to do hormone replacement therapy for a
Yeah.
long time.
that is stunning.
Crazy.
But the
Yeah.
other part of it, I think, you're very gracious in saying your first patient was working with you. But I think the reality is, as a patient, as the citizen scientist laboratory, myself all the time, I've now worked with 3 different practitioners and protocols, and you just have to keep trying. I think in partnership with the practitioner you're working with, find the formula that's going to work for you for that moment in time, and it might change in a year. It's on us as a patient as well to be having this active conversation with our medical practitioner in partnership.
Yeah.
Hmm.
Absolutely. And that goes into the whole issue of, how do you find a menopause practitioner? I know people can go to NAMS, the NAMS site, right? The National American Menopause Society has practitioners. There's also ISWICH, which is ISU. I can get it to you later. It's the International Society for Sexual Women's Health. Primarily, that group, interestingly enough, is populated largely by urologists. And I would say
Hmm.
I went to their annual meeting last year, and it was super interesting because probably 90% of the participants were urologists. I want to say, well, that makes more than 100, but 20% were This is how it felt. 20% were gynecologists. And I think I was one of 2 primary care physicians who were at the entire conference.
Hmm.
And people came up to me and they were like, where are the primary care doctors? Why are you guys not here? And I'm like, I don't know. We need more of that and more representation, more people, more doctors getting interested in this. So what I've been trying to do, because I have a concierge practice as well as a very small hormone track that I'm not able to scale for a lot of reasons we can talk about. What I'm trying to do when people come to me is say, well, I can't necessarily take you as a patient, but here's what I can tell you to ask your doctor. You need
Right.
these tests.
Yeah.
These are the things you should start with. Please go back and educate your doctor, because there's
Mhm.
no reason why you can't go to your regular primary care doctor and get hormones.
Yeah.
Right.
That's a fantastic
Absolutely.
resource to have, like a primer like that. That is a great resource. This is the fill in the blank Mad Libs question set that you want to take in.
Right. And I think, to be honest, I think doctors are now much more interested. There's this pervasive fear of hormones. I still hear it from my breast colleagues. I have a great breast surgeon I work with, and she's like, I put everyone on hormones, and sometimes they'll have to go to her and she'll be like, why, she'll tell them to stop. Then they come back to me and they're like, well, the specialist told me to stop. What
Hmm.
should I do? And then I have to kind of re-educate. And even myself, I needed to do a preoperative exam. Personally, I take hormones. I couldn't see my own doctor, long story. I saw some, substitute physician who actually literally looked at me and said, you're on HRT. And I was getting an outpatient surgery. She's like, you need to stop because it's going to increase your risk of clots. And I was just like, there's so much misinformation, even in the medical profession. So what do you do as a
Absolutely.
consumer, right? Very hard.
Absolutely. Absolutely. Well, we're so excited to talk to you today because, and maybe I have my doctor hat on a little too much when we get into this, but I think we're so glad that menopause is having the attention right now that it's receiving, but I still feel like it's receiving it in these around these very well established conditions. We talk about, which is important, absolutely important. We talk about treating symptoms, first of all, hot flashes, things like that. And then we're talking about bones and building lean muscle, but menopause affects so many of our other organ systems and things that are most likely to kill us, like our cardiovascular. The cardiovascular disease is still the number 1 cause of death for women, and we kind of don't talk about that very much. And we had talked about a little bit about gut health. We don't really talk about that through menopause, and yet we know all of these systems are so interconnected. So we're super excited to dive into maybe what is a little bit below the surface compared to where a lot of these conversations are taking place.
Absolutely. So let's start with heart. I think it's interesting. In conventional medicine is not geared towards prevention, right? So the current recommendations on lipid testing are, every 5 years. So if you're a woman who's maybe 45 or maybe you're 47, you get your lipids tested, sort of perimenopause, and you're fine, you may go 5 or 6 or 7 years before a physician will repeat your lipids. The problem is that once you go through menopause, right around 50, there can be a very, very profound change in your lipid profile, right? Where you actually become, once you lose estrogen, your lipid profile looks more male. And Jen, I don't know if you are as old as I am. When I was in residency, any woman who came in with a heart attack, actually at the time, we would put them on hormones because there was this, it's a well-established belief that hormone replacement really reduces cardiovascular risk. And so because I check lipids every year on my patients, I'm able to actually see the change if they're going through menopause. I can see if there's a change significantly. Often there's a bump in LDL levels, the adverse cholesterol particles, and sometimes there's a decrease in HDL, which are, I know there's an argument about good, bad cholesterol, but for the sake of the conversation, we'll say these are more beneficial particles. And that change can be mitigated again by MHT. But if you're not checking your patients right through the menopause years, you're going to miss that. And I think that's not emphasized enough. I do think, as you said, hormones are so stressed for bone health, symptom relief, skin, but we can't neglect the heart, number one cause of death for women. It's huge.
I don't think anyone has ever explained that to me, that is a condition, a result of being through menopause, right? That my cholesterol was going to be impacted.
Yep.
I mean, Jen talks about it all the time, but I've never sat in with my general practitioner and said, hey, you should be managing this because you should expect it to rise because you're postmenopause.
And I think that's one of the things that I've experienced personally and had conversations with my physician, even with my lipidologist, to say, I need treatment before my numbers get bad. I don't want to react to bad numbers. I've missed the boat there. We know things are going to start changing exponentially and kind of based on my family risk factors and personal risk factors. I was like, I would like to get ahead of this, not be behind this. But it's really interesting because even primary care physicians who are so in tune with doing these things don't connect those dots with I'm a 47-year-old woman. I'm really worried about this kind of exponential increase in the atherogenicity of my cholesterol and what's going on. Can we get ahead of this instead of just react until I meet a certain score on a risk calculator?
Great. Yeah, no, you should be acting before you hit that risk calculator, right? And I think it's really interesting that most cardiologists who treat lipid disorders, it's not part of their toolkit.
No.
It's okay, we'll put you on the statin, we'll do whatever, but HRT is not part of their toolkit, and it really should be. Part of it is if you're not checking, you won't actually catch that transition. And, I don't know how many people nationwide are actually looking at lipids every single year, especially through menopause, but something to definitely ask for and advocate for.
Absolutely. How do you think blood pressure plays into this? Have you seen effective results with MHT in managing hypertension in this time period?
That's an interesting question. I haven't looked at the literature per se on blood pressure effects. I think what I see is a secondary effect of elevated blood pressures because of weight changes, right? So when you go through menopause, it's very common to get that extra fat tire, right? You're starting to distribute fat in more male-oriented. You get the beer belly. So women tend, with estrogen, we get fat on our hips, right? Nice kind of pear-shaped. Once we lose estrogen, we start to get fat in more traditionally male areas. Visceral adipose tissue also tends to increase. And I think because of that, and visceral fat is in itself an endocrine organ, right? And so there's more inflammation. And I think that's the pathophysiology by which you'll see elevated blood pressures. I don't know that there's a direct effect on vasculature per se, but through proxies.
Got it.
Yeah.
I think it's just such the forgotten conversation I think that we are missing when midlife women are seeing their doctors, or even still this hesitation to start hormones for these reasons. I think people are getting more comfortable with starting hormones when it's treating more classical symptoms of hot flashes, vaginal dryness. There's other things that we worry about, bone density, but for treating cardiovascular health, and whether it's in conjunction with more traditional therapies like statin therapy or not, I think it's an interesting conversation. And again, love your idea of empowering your patients. And so empowering our listeners to say, talk to your doctor about this. They may not be connecting the dots. Go ahead.
One of the questions that pops into my mind, and I imagine if people have not been already having a conversation about hormone therapy, is, well, how long? because when the hormone therapy questions sort of got into mainstream, there was this big conversation about, like, all right, if you have to start it after X amount of years going through menopause and you can stay on it 5 years, something like 10 years up to over the age of 60. And I think, Yumi, you framed this one really clearly. So I'm going to ask you to do it again here. But when you talk about the risks to something like your heart health, it feels like you'd want to just continue. Like, why wouldn't you just continue on hormone therapy for something as critical as that?
Exactly. I think, the standard teaching that all conventional physicians receive is lowest dose for the shortest amount of time. And usually it's 5 years to get you through menopause. There's absolutely no reason you can't stay on it till the day you die, right? And I
That's
fully
a
intend
big
to do that
message.
for myself.
Yeah.
So for all the reasons that we're talking about, bone, brain, heart, we can talk about microbiome in a bit. No reason to stop it. I think the question that's a little more controversial is I have a lot of women in their 60s, sort of baby boomers, who feel, because menopause is now all the rage, but they're now 60 and they went through menopause maybe 10 years ago. They're
Right.
really pissed off. They left, they missed the bus. They feel like, the train left the station and they weren't able to get on it. So is it too late to start when you're 60 or over? And
Right.
what I see, this is a much more nuanced conversation. If you look at some of the discussions actually in the menopause world, there's very little resistance to starting any woman on hormones at any age. However, you do have to have a conversation with your patient if they're over 60, about their cardiovascular disease risk. Because in the first year you start, there is a very infinitesimally slightly increased risk of heart disease in that very first year. Super small, but you want to make informed decisions with your patient. And what I do with all my clients who are in that age group is I usually try to risk stratify their cardiovascular risk. So I want to make sure their lipids are under control. And then I also sometimes will send them for a coronary calcium scan to make sure they have no plaque in their coronary arteries. And then I feel extremely safe about starting. There's no reservations about starting. Even someone with risk factors, if we have a very formal discussion about risk benefits, I still have less reservation. I just want to make sure that people are making an educated decision. Most people will tell me that the slightly, and I can't quote you on the exact number, but a very slight increased risk of heart disease in the first year, the benefits still far outweigh the risks for Alzheimer's disease prevention, osteoporosis, risk prevention. We know if you have a hip fracture, that's like a metastatic cancer diagnosis, right? The mortality from that is huge. So preventing all of these other things, I think, is well worth the slightly increased risk of heart disease.
Yeah.
But just a quick answer to your question, you don't ever need to stop. If someone tells you to stop, just say no. I don't need to stop. I will never
Love
stop.
that.
Yeah.
But Yumi, I think that message that you can stay on it as long as it's helping you feel better is a new message that I have not heard that in so many of our conversations that we're talking about with menopause. It's still framed as this, like, oh, it's maybe a 10-year thing you're going to do. But for these, longevity benefits, as well as just, feeling good in your own body, why stop? You don't stop taking a statin if it's helping your health. You don't stop taking your supplements for longevity. So I love that invitation on offer for women to have the conversation with their medical partners that this is a lifelong choice, and I'm continuing to get the preventative benefits and I feel better.
I know my doctor told me, you've been on it 5 years, you need to stop. And I'm like, nope, you're prying it out of my cold, dead hands.
Yeah.
Right?
I think that's exciting.
So
Should we shift gears to the gut health question, or do we have more we want to
yeah,
explore with heart health?
no, let's shift to gut, because I think this is kind of new, will probably be new information for a lot of people.
Yes.
Yeah, so really interesting. A lot of research is now emerging that when women lose estrogen in menopause, there's some profound shifts to the gut microbiome. And so there's certain species that become more predominant and others that become less predominant. And you can have maybe more GI symptoms, more irritable bowel-like symptoms, more discomfort, maybe more bloating. And we all know that there's a relationship between gut health and brain health. In terms of mood and depression and even some cognitive. So I wonder sometimes if some of the cognitive changes people complain about in menopause aren't somewhat connected to gut health as well. So another really strong
Super
reason
interesting.
starting MHT is, I think, it's only going to benefit gut health. I think it's still an area of increased, we still need to, there's so much we don't know about gut health. If you have your stool microbiome tested, and it exhibits certain number of bacteria on day 1. Is that going to be persistent if you repeated your test on day 5? We don't know. What I do know when I do test patients is I'm looking for patterns, right? Overall, is someone well balanced? I don't know that we know enough yet to say, okay, if you have more of this type of bacteria versus this type of bacteria, it signifies XYZ. But I think we can say as a snapshot, if your microbiome is really unhealthy, here's some things that you can do to mitigate that. And MHTB may be one of those things.
Does form factor for the hormone therapy play any role if you're concerned about gut? Like, does it matter if you're oral or if it's topical or if it's vaginal? It has the same efficacy for that specific targeting?
Yeah, I mean, that's more a question of what's been studied in terms of safety and efficacy. So the rule of thumb is estrogen and testosterone, always topical.
Always
You
topical.
can't. Always topical. Progesterone can either be oral or topical in a cream. The advantages of oral progesterone are it metabolizes through your liver. And you may or may not know this, but the metabolite is extremely soporific. So it really puts you to sleep. It's really calming. If people remember their third trimester pregnancies, that's when progesterone's super high. You're just in love with everything. Everything is copacetic, over the morning sickness. So high progesterone is really anti-anxiety. So a lot of women who have trouble sleeping at night, the oral progesterone right before bedtime is great. And then for estrogen and testosterone, I do it topically because there's some thought that metabolites through the liver are potentially maybe more harmful. I still don't really buy that, but it is a safer way of administering hormones, and the absorption is quite good through the skin. So that's sort of the rule. I don't know that and because you're using testosterone and estrogen transdermally, you're not really using gut. So gut issues don't affect absorption so much. So, yeah.
And as you're thinking
What I will say regarding, just to interject, the vaginal microbiome is a really interesting topic. I've been particularly interested in this because, contrary to your gut, the vaginal area is actually dominated by one dominant organism. You don't want a diversity of microbes in your hooch, right? You want it to be like one colony that keeps pH normal. What happens when you lose estrogen vaginally is you actually create more of a milieu for more different vaginal strains to take over, and that predisposes you to UTIs and bacterial vaginosis. All of a sudden, you see this really increased rate of BV and UTIs in menopausal women, and it's because we want that predominant lactobacillus, I think, reuteri, if I'm remembering. Anyway, it's one of the vaginal strains. You want predominantly that strain in the vagina, and it's the only area in our body where we just want one dominant strain. So vaginal estrogen helps with that.
Okay, so that's not really the only lever that you can bring to help there, or is there something you
It's
do?
really,
With diet
it's really bad. It's somewhat dietary, but it's really vaginal estrogen. The bacteria somehow actually use estrogen as a substrate to replicate, and when you lose estrogen, there just wreaks havoc. And all these other species come in and cohabitate, and that's not copacetic for the vaginal environment.
One thing just to share with our audience, because this was something that I definitely, we always joke that we're like N equals one. We're our own laboratory. My observation from N equals one on this is my primary symptom with menopause was the increase in UTIs. So I didn't have a lot of hot flashes. I didn't have a lot of vaginal dryness, any of that, but I had just an increase in UTIs. And so when I was originally prescribed the topical estrogen, I actually got an even more frequent UTIs. And so there was a change to go from the cream to go to a vaginal insert tablet. But one of the conversations I was having with my practitioner just earlier this week in this history was that in some of the vaginal creams, there's a delivery mechanism encased around the actual cream that does create some sensitivities to some people for UTIs. And so, and just sharing that information, her recommendation was she works with an apothecary to really compound it in a very clean way. And I was getting, over the counter stuff from the drugstore that was prescribed, not over the counter, but prescribed through the drugstore. And so it is this idea of experimenting and continuing to experiment to find the right way it lands for everybody's body, as it's all different, because I care now about having the right microbiome. And I want to make sure that I'm trying to bring that tool to bear and not being afraid of the UTI consequence.
Yeah, no, I think it's a good point. I mean, I know compounding pharmacies often get a bad rap in conventional medical circles, but it's often it's the incipient that is what you're reacting to. So you can have things compounded in a very neutral, vehicle so that you don't react to it. That's sometimes
Yeah.
very important. So if you have a good relationship with a reliable compounding pharmacy, I think the quality is excellent and there's no cause for concern about quality.
You touched on this with the gut brain connection, but I want to go back to cognition and dementia prevention. As you know, I think that's another thing that I know it's near and dear to my heart, as I just lost my mom to dementia. But I also, I think most of us, that's a huge fear for us in aging, is developing cognitive decline or experiencing cognitive decline, developing dementia, and those things. So kind of interested in your opinion on the role that MHT plays directly in helping prevent dementia versus kind of enabling the other areas like better heart health, better lipid profiles, all of these other things that are also supporters of healthy cognition as we age.
I personally think there's enough data now to suggest and show that estrogen supplementation and MHT overall reduces the risk of Alzheimer's disease directly. We have huge numbers of estrogen receptors in our brains, and women have a twofold increased risk of Alzheimer's compared to men. I think it's partly because we're losing that very protective effects of estrogen, and all those receptors are suddenly dried out. I know, following the work of Richard Isaacson, who's a prominent neurologist studying Alzheimer's, and he's looking at people who have the E4 allele, which increases your risk significantly. So his protocol is he puts all of his E4 patients on supplemental estrogen. And he actually tries to drive something called the FSH, which is follicular stimulating hormone. He wants to get that down to sort of premenopausal levels. So he's actually looking at FSH levels, increasing estrogen doses to get to a target to suppress the FSH in his, patients with a strong family history of Alzheimer's or E4 allele. So I really think incontroversial evidence that HRT hugely helpful for dementia prevention.
Now, with that, can I ask a quick question? Because there is controversy about measuring estrogen levels, and in perimenopause, we understand that they're all over the place, so it's probably not helpful. But some hormone experts that we read are now saying after menopause, it is helpful because your physiologic levels are flat. So whatever you're supplementing with, you should be able to get to a level. So in work like that, do you think it is productive to have a conversation that I want an estrogen level, or has that been looked at yet? Like a target estrogen level kind of once you're in menopause and supplementing versus still using like a third marker, like an FSH level?
So that's a very controversial question. I have a number of thoughts, and so this is my own journey, and I'll just be very transparent. Coming from the integrative medicine world, the teaching is to measure saliva hormones. And I will say in the perimenopausal timeframe, it is possible to measure hormones. And I do it all the time. You want to measure if you're having a normal cycle, you want to measure on day 19, right? Because that's sort of, we know what levels are supposed to be on day 19. You could be all over the place. So you can kind of approximate what is an equivalent day 19. But what we often see in perimenopause is progesterone plummets first, right? So women in perimenopause will definitely often benefit from progesterone supplementation before they need estrogen. So you can have levels measured even, if you're in that perimenopausal period. I think that gets overlooked. In menopause, I check levels on my patients. It takes about 3 months after starting treatment for receptors to saturate. So I check at 3 months. And then if I make an adjustment, I check again in 3 months. And then if someone's stable, I check maybe every 6 months and then maybe every year just to sort of see where they are, or if anything any symptoms fluctuate. And sometimes you'll find over time, people will have increased needs for hormones, or sometimes their needs will decrease depending on multiple variables. Now, the reason this is controversial is the following. Most conventional doctors don't check levels at all. Like right now, if you go to MIDI Health or if you go to MyAlloy, they're putting you on like a slam dunk, 0.05, probably estradiol, 100 milligrams of permetrium, and they're saying, see you later, you're fine, or call us if you have symptoms. And there's nothing wrong with that per se. The vast majority of women will do fine on that, and it's better than nothing. However, I still feel like, having done this now for almost 10 years, that I've seen enough cases where levels, when I check them, almost always correlate with someone's symptoms. So if someone's having vaginal bleeding, I almost know that their estrogen is too high compared to their progesterone. If their boobs are tender, same. If they're gaining weight, often it means that the estrogen and progesterone aren't well balanced.
Mm-hmm.
The reason this is controversial is because, and I'm very aware of this and sensitive to this, there's a sort of myth or supposition that integrative doctors are measuring hormones and, quote, personalizing them for their own personal gain. In other words, that we're, making money from the testing and we're tweaking hormones and we're selling something that's not really achievable. I don't get any money from the testing. I tell them I to give my patients their kits. It's saliva. They pay the company. I don't upsell. I don't believe in that. I get the reports. I do, sometimes tweak their dosing and I go from there. I think it works. I know there's a lot of controversy too because these tests are not FDA approved. And there's a lot of also question about saliva versus blood and what measures actual tissue levels. So the teaching that I follow that saliva actually more accurately measures tissue levels of hormones than blood. There's a whole contingent of physicians who believe that blood is the way to go, especially with testosterone, that you get much better and more accurate measurements of serum of tissue levels of testosterone through looking at blood. Mm-hmm. So I've kind of gone back and forth. Should I use blood? Should I use saliva? I use saliva because it's what I've done and I see that it works. But what I've started doing now is actually at the same time someone does saliva, I'll do a blood test so that I can start to see where someone's and what the correlation is.
Describing that, like if you did this when you were like 30, right? Would you have a baseline estrogen, to Jen's original question, that like you'd loop back and say, I want to get back to that level? Or are you just measuring it right now to say, how are the hormones interacting?
So good question. Estrogen, as you know, is so cyclic, but I would say if you measured on day 19 when you were 30, you should still have the same hormone measurements on day 19 when you're perimenopausal. And what we're trying to do when we replace, at least in the salivary testing world, is we're not trying to get you to super therapeutic levels, right? We're trying to get you to a level based on thousands of women that have gone through these testing, they have defined a reference range that's target for estrogen and target for progesterone. So we're trying to get you in those target levels. So if you're outside that level and too high, then we lower your dose. Or if you're too low, obviously we go up in the dose. And then also very important is looking at the progesterone to estrogen ratio. I find that's very important because if you have too much estrogen relative to your progesterone, again, it can cause spotting. You can get more breast tenderness. You get more weight gain. So you want to have that ratio nicely balanced. And so I look at those things very carefully, but not everybody does.
Yeah, I've not heard that one either. Like when I've been talking to different practitioners.
I think it's so interesting. And this goes back to my continued frustration with the confined definition of what women's health is if you take thyroid hormone, we're checking your thyroid levels. If you take even men who are taking testosterone, you're checking testosterone levels. And yet there is still this belief that it is too complicated to test hormone levels in women, even postmenopausal women. And, I guess I would want to know as a patient, like, okay, you've given me something that we can monitor the levels that, and to Lindsley's point, it is a little bit of, I don't want to say trial and error, but you start somewhere and then build on top of what you find when you start and adjust as symptoms are changing, et cetera. And so I do think it is interesting that the conversations around this is, doctors are profiting or et cetera, when it's like you're just trying to take care and monitor patients. It's just, I'll get off my soapbox, but it just is, it's exhausting, right? Because it's like you're trying your best to take care of these patients and to treat them as specifically as you can.
Exactly. And that's been part for me, the challenge of scaling, right? Because if I'm checking hormones every 3 months on patients, pretty soon, if you get up to, 50, 60, 70 patients already, that's a lot of labs you're looking at and having to tweak. And so I've actually had to limit the number of women that I can help because I can't continue to do that and provide that level of care. So I'm trying to pay back or push back by saying, okay, you need to go to your physician at a minimum and try to educate them to at least get this ball rolling and get the conversation started. Because I do think that services like MIDI and My Alloy are really filling the gap for women who really need
Mm-hmm.
hormones. To be honest, really nothing wrong with sort of a cookie cutter approach and not measuring levels as long as you're feeling fine.
Mm-hmm.
It's when, when you're not feeling fine or you may have some side effects, then you may need a little bit more guidance. So
Yeah, because as you talk about equipping women to have this conversation with their practitioner, I'd want to know, like, what is the ratio of estrogen to progesterone that we should be looking for? How does testosterone factor in? Like, I'm not even sure I would know how to frame the questions other than, hey, is my ratio looking good? But I don't know what it should be, right?
I mean, my guess is most doctors will look at you slanty eyed and be like, I have no idea what you're talking about.
Yeah, but when you
Yeah.
go with your lipid panel and you kind of know directionally
Right.
and hear from your doctor, wow, this is in the red zone, or no, it's not, because you've been educated. It's out there, but I've never even had a
Yeah. Well, the
understand.
nice thing about the saliva testing labs are that you are given reference ranges and you're given graphs, so you can see if you're outside of the reference range and target. And there's specific targets for menopausal women, and so that gives you really nice guideline.
That's great.
Yeah.
Okay. So we try to leave our listeners with probably the most actionable advice that we can, especially when we are encouraging. I feel like a lot of our job is education and to say, this is how you have a better conversation with your healthcare provider, exactly what you are reinforcing. If we had to pick the top 5 things that you would want patients to start to have conversations with their healthcare provider about based on hormone therapy and menopause, what would those 5 things be? So our listeners can go in and have just a higher level conversation.
Yeah, what's interesting, I just had one of my best friends came over and she's like, Yumi, I'm going through menopause. I don't know what to ask. I don't, what should I do? So I gave her a list of labs, and I'm happy to write that. I don't know if you have like a link, but I think certain labs you should ask for, which would include FSH, testosterone levels, sex hormone binding globulin, obviously progesterone and estrogen levels, and DHEAS. Those are all the labs I look at. You can start with blood, even though I do saliva, but we're talking conventional, so let's go with blood.
Mm-hmm.
I think the issue that people might run into is, okay, what do I do with the lab results if my doctor doesn't know what to do with it? How do I find someone who can help? And that's where second you might want to go to a NAMS provider, a physician who can help interpret that. But then at least you have something to work with as a baseline. The other thing important to know, as I said, if you're in menopause and your cycles have stopped, you can check blood tests anytime. It doesn't matter. If you're in the perimenopausal period, you do want to try to do it on day 19 because that's when the reference ranges are sort of established for where we want you to be. How many was that I gave you? Labs.
That's perfect. Okay, let's start with labs. Okay. And then, talking about some of these other things, would you, I guess this is still with labs, but reminding someone to have their cholesterol checked more often.
Absolutely. Yes, I would definitely, if you're entering menopause, it'd be very interesting if you can convince your doctor to get kind of a baseline if you don't have it right before menopause. And then if you're in that transition where you're having irregular periods or you've stopped having periods, repeat your lipid panel and compare and see if you've had any significant changes. Certainly if you have a strong family history, I would encourage that. That should be happening anyway. But if it isn't, that's something to ask for. Absolutely. I would also a lot of, the U.S. Preventive Task Force does not recommend bone density testing till 65. Crazy. You should get a baseline bone density right around menopause, so you know where you are. We know we reach peak bone mass in our 20s, but at least to have a baseline perimenopausally, really important because we start to lose bone density dramatically every year after menopause if you're not replacing. So those are, lipids, those sex hormone labs, bone density at a very minimum. And the other thing I really like to have people do, if their physician has it, is to get a body composition scan.
Mm-hmm.
So it's not just weight, it's not just BMI, it's percent of body fat, it's percent muscle mass, it's those ratios, it's the visceral adipose tissue you want to avoid. All of my menopausal women, I put them on body comp scans all the time. Many of them are great with their fat percentage, but they're not great with their lean muscle mass. And we all need to work on lean muscle mass. So knowing that is really helpful. And especially tracking that as you go through menopause, because you don't want to lose, you want to keep it.
Yeah. So you mean the other 2 things that you mentioned, the gut microbiome, so do you recommend that kind of a testing, as well as, I mean, is there a vaginal microbiome test?
There's actually a company out there that does vaginal microbiome testing. That's more useful if you're having recurrent UTIs or bacterial vaginosis and you want to see where you are. I would say probably for gut microbiome testing, I would just know that being on MHT helps your gut microbiome. I don't really test my gut microbiome unless someone's really having severe symptoms of irritable bowel or diarrhea, constipation alternating. But know that if you're having those symptoms, it could be menopause.
And then, Yumi, when you're saying MHT, are you presuming that it's all three? It's estrogen, progesterone, testosterone?
Yes.
Yeah, because that is another thing that I think so many women run into is testosterone is not on the table.
Yes. Absolutely. And I'm guilty as charged. I think when I first started doing hormones, I became very comfortable with estrogen and progesterone. I was a little bit afraid of testosterone. Now I'm just like giving it out. I'm not giving out like candy, but I'm much less reluctant to prescribe it. I'm seeing much more benefits and becoming more comfortable, but it's a matter of comfort. Again, I think that it's going to be a slow sea change. What I see happening and I think will happen is probably, hopefully more conventional physicians will prescribe progesterone or permetrium and estrogen. I think the testosterone is still going to lag a little bit, but it should be part of the whole equation.
Got it.
Good to know.
Yeah.
Wow. This is great.
So good. I mean, so much great information and so much empowering information, right? That yes, people like you are so few and far between that we all can't have access to you as our physician, but how to have an enlightened conversation with your own healthcare provider and really advocate for yourself and what you need, I think is really so important. And being a physician, I feel like that's what will slowly chip away and change the way physicians are educated and trained is if patients keep coming to them with these questions that they have to seek out, that hopefully eventually we see those shifts and physicians come out a little more prepared.
All right.
Great. Well,
Well,
nice
thank
to
you
you
so much,
both.
Yumi. Thanks for the flexibility and for dialing in.
We made it work.
Happy birthday to your dad.
Yeah. Thank you. All right, you guys have a great afternoon. Take care.
Take care.
Thank you so much for spending your time with us here today. If you liked what you heard and you got some tips on how to live better right now and for the long haul, please help us reach more midlife women. Please share and rate and like this show. And we can't wait to continue the dialogue with you on our next episode. Until then, thank you. It's time.